Secondly, health habits are only moderately related to each other, which, for example, the person who exercises consistently may drink, may smoke. So just because you engage in one good health habit doesn't guarantee that you have no poor health habits and you engage in a bunch of health promoting behaviors. So because of this, health habits and behaviors must be tackled one at a time. So to complicate things even farther, health habits can change over time. So a person who can successfully quit smoking for a year, but start again because of a stressful situation. So why are health habits so unstable and so unrelated? First, different factors may control different health habits. Diet may be related to finances, access to nutritious foods, but in comparison, smoking may be related to stress. So it's not necessarily the same factors to tackle to change a health habit. Second, different factors may control the same health behavior, like depending on the person and depending on their situation. So for instance, say two people overeat. We're talking about the same health behavior. However, one person's overeating may be due to social or cultural factors, and for the other person, it may be a stress response or due to pathological symptoms such as an eating disorder. So there's no one-size-fits-all approach to health behavior change because people may need to address different factors to change the same behavior. And lastly, over time, the factors contributing to and controlling a health behavior may change. So this can occur both over the history of the behavior, meaning from the onset of the behavior to the present, and over a person's lifetime. So over the history of a behavior, the factors sustaining the behavior may change. So for example, a smoking habit may have begun because of peer pressure. However, it may be sustained because of the addictive aspects and possibly because of stress reduction. Over the lifetime, the resources we have may change. So for instance, in childhood, regular exercise may have been practiced because it was built into the curriculum, like you have gym class, you have recess, etc. But in adulthood, this behavior needs to be sustained and practiced intentionally. There's no one making sure that you do it. So over the lifetime, the things that we need to make sure we practice these health behaviors may shift. So in summary, when talking about modifying health behaviors, it's really difficult because the picture is so complex and changes with every person. The factors to target are different for different people. They can change over time. The benefits of changing health behaviors aren't seen for a while. They may never be immediately seen. You may just never get a chronic illness and not actually see anything specific. And this may be less appealing compared to the often immediate, though short-lived, benefits of poor health behaviors. So because it's so difficult to change health behaviors once they're established, health habit interventions have focused on those who can be best helped, meaning children and adolescents that haven't developed these habits yet. So getting back to that idea of primary prevention. So, health habits, when intervening with children and adolescents, are affected strongly by socialization, which is the influence of caregivers as both teachers and role models. So, caregivers instill teachings in their children that later become automatic, such as eating breakfast, brushing your teeth, etc. And they also modify these good health behaviors. So, I can imagine my parents telling me I had to wear a helmet when I was riding my bike, but then I'd look and see that my dad wasn't. So then it creates this habit of wearing my helmet because I was told to, and yet there's this bit of misunderstanding or disbelief in the importance because it wasn't being modeled. So this is a pivotal window for instilling good health habits because However, instances in which the caregiver is unable to instill the habit or reinforce it, they can slip through the cracks. For example, a single parent household in which one caregiver must assume all responsibilities and earn income to provide for their family, or high stress households with unwell caregivers, marital disputes. So instead, no one's perfect and everyone's doing the best that they can. But it's understandable that all households are less than perfect, and caregivers can possibly miss a behavior. Behaviors can slip through the cracks. And it's very important to recognize this as a pivotal time to instill these health behaviors in the children. As children grow into adolescence and young adults, there may be a resistance to these teachings that our caregivers are trying to instill in us. And they may be exposed to poor health behaviors like smoking and alcohol. So, if caregivers are unaware of these practices developing, and if an adolescent's peers practice such behaviors, there's a greater likelihood that the adolescent will develop them. So, identifying teachable moments, so suitable times for modifying health behaviors, and maximizing on them are imperative for instilling good health practices. So, like I just said, teachable moment is when it's a good time to try and modify these health behaviors, like childhood prior to adolescence. In school, like in university, we often talk about as a GA or as an instructor when to utilize a teachable moment over a consequence, for example. So when is it a good time to just try and take this as an opportunity to educate instead of just throwing an arbitrary consequence at a person? Other teachable moments can be, instead of just reinforced by the caregiver, built into the healthcare system. So things like required vaccinations for young children, and with some schools requiring documentations for these immunizations. When isolating opportune times for teachable moments, health psychologists look for a window of vulnerability, or times when people are first exposed to those poor health habits. So if we're trying to say, teach children and adolescents not to smoke, want to find out when they would first be exposed. Because if it's too early, they may forget, or they may discount the information because they may have never thought that they'd be even tempted. And if it's too late, it's too late. So you want to find those windows of vulnerability. So for instance, there's a window during middle school when students are first exposed to smoking, alcohol, drug use. However, although a lot of these teachable moments occur in childhood and adolescence, it's not just then. Pregnancy is an example of another teachable moment. Many pregnant individuals will partake in a lot of behavior changes to protect their developing child. So although most teachable moments and windows of vulnerability occur during childhood and adolescence, there's a lot of opportunities for adults as well. So in addition to children and adolescents, interventions may focus on those at risk for developing an illness. So for instance, individuals with a family history of a disorder may have a personal risk that is higher than those without this family history of the illness. So these would be a population of at-risk individuals for a certain disorder. So as with anything, there are benefits and issues of applying interventions to at-risk individuals. So looking at the benefits, working with at-risk populations can be an efficient use of funds allocated for health promotion. So diseases may be altogether prevented by instilling health behaviors in people to offset their risk. For example, working with individuals with a family history of coronary heart disease and helping them stop smoking may later prevent coronary heart disease. So this is definitely a very efficient use of funds and a very effective population to work with. And lastly, focusing on at-risk populations can help to identify other risk factors, because one factor does not guarantee the development of a condition, right? So not everyone with within an at-risk population is going to develop whatever illness they're at risk for. So what is it about those that do? So what is it about the people within a family with a history of hypertension, the ones that do develop hypertension, what is it about them that made them develop hypertension and not their other family members? So by looking at the ones that did eventually develop the illness, we can identify other factors that are risk factors for that particular illness. Now, looking at problems with intervening with at-risk populations, there is the issue of people failing to correctly perceive their risk. Most people view their unhealthy behaviors as widely shared. Like, everyone drinks sometimes, everyone smokes, but their health behaviors, in comparison, are distinctive. So I eat healthy. So people tend to put a lot more specific emphasis on their health behaviors that they do, and a lot more generalization on their negative health behaviors. Everybody smokes, but I eat really well. So because of this, people may be resistant to change because they see so much more positive coming from the good health behaviors that they do, and don't put as much weight on the poor health behaviors because everyone does them. Secondly, informing people about a risk factor can result in needless worry or even hypervigilant behavior. So there is the risk of how people react to knowing that they're at risk. So possibly adding stress that can impact their health negatively. Farther, such worry may result in a defensive reaction, with people minimizing the significance of their risk, possibly avoiding health services to avoid facing their risk. So sometimes we avoid things that we're scared of. So it's possible that people may just not want to know and just not want to deal with it. Also, there's ethical issues we have to think about when intervening with an at-risk population. So for instance, when is the right time to tell someone that they're at risk for an illness? There's really never a good time. So when is the ethical time? Just because you're at risk doesn't guarantee that you're going to develop the illness. And engaging in health behaviors doesn't guarantee that you're not going to develop the illness. So when's the right time to warn someone and disrupt their life that way? Second, instilling risk reduction behaviors can actually increase psychological stress. So people can react poorly to information like anxiety or depression. Like I had just mentioned about this hypervigilance, this increased stress. And this is especially possible for people who are already predisposed to mental illnesses like depression and anxiety. So you don't want to warn them about having a higher risk for an illness and then have them develop psychological distress as a result. Third, some conditions may have no intervention, especially when it's genetic risk factors. So what's the ethical answer for telling someone they're at risk for something and there's really nothing we can do? So for example, if you have the Huntington gene, it's genetic. There's no intervention to change your genes, at least not at this point in time with science. So this raises the ethical concern of informing someone of a genetic risk that can't be changed and possibly leave them feeling doomed. Last, there's a concern of the impact of emphasizing inherited risks on the family dynamic. So imagine, using that Huntington example again, you were told that you tested positive and you know you got it from your family. What's that going to do with the family dynamic? How will you react to your family? It's not like they purposely gave you the gene, and if it wasn't for their genetics, you may not have gotten it. So individuals that are told that they inherited a risk from their family may exhibit a behavioral response toward their family as a result, possibly due to anger, a difficulty accepting this risk that they've been unwillingly given, or resentment. So like most ethical issues, there's no clear answer to any of these. it's just things that really need to come into consideration when working with an at-risk population. And a third population to focus is older adults. So, health promotion with this group focuses on several main behaviors: maintaining a healthy, balanced diet, maintaining regular exercise, reducing accidents, controlling alcohol consumption, eliminating smoking, reducing inappropriate use of prescription drugs, and obtaining vaccinations, and maintaining social engagement. So, by age 80, your body, it's pretty much anything goes. It's completely understandable for something just to happen in your body at that point. So by age 80, health habits are the major determinant of whether a person will either have a vigorous life at that age or an infirmed, unhealthy old age, which that means health habits for this population can make or break how you age, whether you age gracefully or uncomfortably. So, proper diet and exercise keep older adults mobile and able to care for themselves. Among this population particularly, exercise doesn't need to be strenuous. You don't need to have them doing burpees. But it has particularly strong benefits in maintaining health among this population. So even if they just go for a walk in their neighborhood or go swimming or do just some lightweight work or Pilates work, it doesn't have to be strenuous, and it has huge benefits. Reducing accidents by eliminating unsafe environments, installing safety measures like grip bars, may prevent injuries that can lead to numerous health complications. Controlling alcohol and eliminating smoking, we already know, removes dangerous substances that can, but with this population, they can have especially negative consequences because there's a lot of metabolic changes in their body at this age. Proper medication use also is essential. So one of the first things I thought of was the amount of pills people at this age tend to take, and sometimes among closer look, they might not all be needed. So sometimes there's some over medicating or excessive medication that can be removed. And financial restraints or unpleasant side effects may impact medication and adherence. And older adults may be not taking the medication as prescribed. Maybe you save money or avoid side effects, or they don't find them helpful. So people who don't take their medication as prescribed are more likely to experience health problems in the next few years. Regarding vaccinations, flu is a major cause of death among older adults and is related to heart disease and stroke. So obtaining the flu vaccine every year is important for this population, and any necessary vaccine. So with everything going on right now, 99.9% of nursing homes or assisted living facilities, etc., are closed to any visitors, and because they're so susceptible to getting an infectious illness. So as you can think back to the discussion about the immune system, as it ages, it's not as strong. So this population is more susceptible to falling ill because the immune system just doesn't have the ability to fight it off. Lastly, social engagement is less obvious but very important determinant of health for older adults. Depression and loneliness are really common. As you could imagine, individuals can't engage in as many things that they used to do. People close to them will begin to die because you're all getting older. So resulting loneliness, isolation, depression can have negative effects on their health. So increasing social engagement can lead to better health outcomes. I read a study a long time ago, maybe even like in social psychology class in second year undergrad. And what I do remember is that older adults that were given a plant to take care of had better overall health and functioning after a certain amount of time compared to those that didn't, because it gave them something to take care of, something to do, something to engage with. So It's obviously not the same as social engagement with another human, but giving some kind of engagement can do wonders for the health of older adults. So when it comes to changing health behaviors, a lot of times it involves changing attitudes towards health behaviors. So there are three main strategies when we're trying to encourage attitude change and consequently behavior change. So the first is educational appeals, which are used on the assumption that people will change their health habits if they have good information. So if they know how bad this is for you, they won't do it. So communication factors like short, clear, and direct messages, colorful, vivid messages, experts, prestigious, trustworthy people communicating this information have been identified as some factors that strengthen educational appeals. So you can just imagine preferring just a quick, short, colorful, bold message of, smoking kills compared to a poster that has like a huge paragraph of information. In comparison, fear appeals, as the name suggests, assume that people will change their behavior if they're scared that the behavior is hurting their health. So kind of scare them straight idea. So you can think of the images on cigarette cartons, like people's teeth, a heart of someone who's been smoking, commercials of drunk driving accidents, the commercials of people with COPD. The one that always gets me, if you hadn't guessed yet, is, I don't know if you've ever seen the one where it's someone saying goodbye to their dog and then they never come home and the dog is waiting for them to come home because they drove drunk or they got in the car with someone who drove drunk or they were hit by someone who drove drunk. So it pulls at those emotional factors like fear to get you to change those health behaviors. So, however, it's not just any fear. There is a strategy for instilling fear because too much may undermine the behavior change. Go back to that too much stress. You can't effectively function, eliciting too much anxiety. And fear alone may not be sufficient to elicit change, and action recommendations may be needed. It's like, I'm scared, but I don't know what to do. So it may not be enough just to scare someone. You have to give them something. Like, yeah, this is scary, so do this instead. And this is how to do it. And last, we have message framing, which is a much more strategic way of framing a health message. So it's how a message is phrased depending on the personal characteristics of the target audience. So, as stated, there's no one-size-fits-all approach. So what works for one group may not work for the other. And a health message may be phrased in different terms. So specifically in positive or negative terms. So things like warning an individual about the dangers of the flu. So that's kind of a negative way, like the flu can kill, the flu is bad. Or marketing the life you can enjoy if you avoid the flu. So that's more positive. Like, the flu is bad, so look at this amazing life you can have if you don't get it. So there has to be a decision about when to use which way of framing the message. Messages that emphasize the problem, so more of a negative frame, seem to work better for behaviors with uncertain outcomes. So this is really, really bad. We don't know what the outcome is. If you anything's better than getting this, basically. Or behaviors that need to be practiced only once. Like, the flu is really bad, so get this vaccination once and you're good to go. And issues of which people are really fearful. In comparison, messages that stress benefits, so positively framed, are more effective for behaviors with certain outcomes. So if you know something good is going to come out of practicing a health behavior, forming it in that positive way is going to be much more effective. So attitudinal approaches to health behavior change have been formalized in specific theories. One early attitude theory of health behaviors is the health belief model, which posits that two factors determine whether people will practice a health behavior. And these are whether they think there's a threat to their health and whether they think that a health behavior will reduce the threat. So is there something to worry about? Will this deal with that thing? 3 factors influence the perception of a health threat. So influence whether or not you perceive a threat to your health. First is general health values, like whether you value or you have an interest in your health, compared to whether you think it's just due to chance and there's nothing you can do. Specific beliefs about personal vulnerability to an illness, so whether you think that you're at risk of getting it, and beliefs about the consequences of a particular illness. So again, to use COVID as an example, people who think I'm not really vulnerable, I'm young, I'm healthy, I'm not going to get it. The death rate is really low, so if I get it, there's like a 95% chance I'll survive. Things like that might create a lower perceived risk compared to people that are like, I have asthma, I'm older, I'm really young, I have immune deficiencies. There's a lot of lung scar tissue. Even if you survive, that'll have a higher perceived risk. In comparison, whether a person thinks a health measure will reduce the threat, so say you've recognized there's a threat, whether or not you perceive a health measure will reduce that threat has 2 subcomponents. The first is whether they think the health behavior will actually be effective. So, do I think it'll actually do anything? And the second is whether the cost exceeds the benefits. So again, if you think of your Healthy Change Journal, there's the appendix in which you complete kind of like a pros and cons list of the benefits and the limitations to making a behavior change. So everything has like kind of a both sides. There's an exchange. There's costs and benefits. So there are costs to a change. And if you think the benefits exceed the costs, you'll perceive it as more of a reduction in threat than if you think the costs are greater, it's just going to make more problems. So this health belief model has been used to increase perceived risk and perceived effectiveness of steps to modify a broad array of health habits, like emphasizing the benefits of health screening programs and the dangers that these programs help you to avoid. We'll talk about those in the first part of chapter 4. However, if you remember back to chapter 1, people need to believe they can make this change. So one shortcoming of this model is the exclusion of self-efficacy, which, as you should recall, this is one's ability to control their practice of a particular behavior. People with higher self-efficacy are more likely to make a change because they believe they can. So, a second major theory is self-determination theory, which builds on the idea that people are actively motivated to pursue their goals. People have goals and they want to get there. So within this theory, 2 components are identified as fundamental to behavior change, and this incorporates an idea similar to self-efficacy. So the first is autonomous motivation, which means that when people feel they have free will and choice when making their decisions, they're more likely to make it. So it's kind of like when someone tells you to do something, you don't want to do it, even if it's something you would have done already. Like, I love to read, and yet when readings are assigned to me, all of a sudden I have no interest in it, even if it's something that's interesting to me. If it's something you feel you have free will and choice to do, you're more likely to do it. And second is perceived competence, which is when people believe they are capable of making the change, so similar to self-efficacy. For an individual to successfully change a behavior, they must feel like they are making this choice freely and are competent to make the change, similar to self-efficacy. So people don't really like feeling forced into things, and they want to know that they can do it. So, in comparison, someone making a behavior change, like reducing alcohol consumption because they were told to, maybe it was part of a rehabilitation program or a stern warning from their doctor or something, they'll have a lack of a sense of autonomy or control, which may undermine their commitment to change. However, if they choose to reduce their alcohol consumption themselves, they may be more intrinsically motivated to stick to their goals because it's their goal that they made. So you may end up in the same place, Or you may be trying to get to the same place, but be more effective when you feel like you've chosen to. In a similar vein, there's the idea of implementation intentions that may be integrated into a model of health behavior change, which integrates this idea of conscious processing. So I'm choosing to do it, I know I'm doing it, with automatic behavioral enactment. And we know that when things are automatic and habitual, we're more likely to do them because they're automatic, they require less effort, conscious effort. So when a person wants to engage in a behavior, they can make a plan that links environmental cues to goal-directed responses. When I do this, I will do this. So think about trying to integrate a morning workout into your routine. You may say that when I'm done breakfast, I will do yoga. So after you finished your breakfast, you put your dishes in the sink. This can act as an environmental cue to direct you to enact your goal-directed response of practicing yoga. So this theory highlights the importance of planning, not just deciding you're going to do something, but planning how, when, and where to implement a behavior, to plan ahead. So this is similar to identifying barriers that may get in the way. Like if you just decided I'm going to do yoga every day, you may find, I don't know when, I don't know if I have the time, I need to do all these other things. So this theory includes the idea of forming an implementation intention to delegate the control of the goal-directed response to environmental cues, which means it can elicit the behavior automatically. So when this thing happens in my environment, that's going to act as a cue for me to do this action. So once I'm done with my breakfast and I've put my dishes in the sink, that environmental cue will make me go and do my yoga, my goal-directed behavior. So over time and through repetition of this environmental cue and the following behavior, this health behavior should become habitual and not require conscious action. So you're essentially conditioning yourself to do the behavior. So there's been a lot of studies on different ways to implement behavior change and different strategies. And one main approach involves the cognitive behavioral theory, or CBT. So CBT approaches focus on the target behavior itself and the conditions that elicit the behavior and that maintain the behavior, and the factors that reinforce it. So in a nutshell, CBT focuses on thoughts and behaviors with the assumption that your feelings and your emotions will adjust as a result. So for example, when I'm explaining what CBT is to a client, I may say, I can ask you to snap your fingers. So can you snap your fingers? I can ask you to think of a purple elephant. Now, can I ask you to just stop being anxious? It'd be nice, but no. So CBT focuses on thoughts and behaviors because we can directly work with them. And the theory is that feelings can adjust as a result. So with CBT, complementary methods are used to intervene in the modification of a target problem. So CBT has homework, basically, and the context in which the problem occurs. So you look at the factors in which a target problem occurs and modify the context and the problem itself. CBT can be done individually or in a group. So within CBT, self-monitoring is a foundational technique to understand the dimensions of a person's poor health habit before even attempting any change. So in self-monitoring, a person assesses the frequency of a target behavior and its consequences. Much of our daily actions are habitual and they may happen and we don't realize how often, how long we've engaged in them. So to know what we're changing, we need to know the parameters we're working with. How often do I do it? How long do I engage in it? When is it happening? Did something lead up to it happening? So this is the same as that baseline frequency chart that you'll make for your first change journal. You need to know what you're starting with. So to self-monitor, first, you have to distinguish what the behavior is that you're trying to change. It can be obvious, like I don't want to smoke, so when I've smoked versus when I haven't smoked. And it can be more obvious, more subtle. like what the internal urges are and the craving. When did those even occur? So before you smoked, you probably had an urge to smoke or like a craving for a cigarette. When did that happen? That might be a little less obvious. So in self-monitoring, a person learns to distinguish the behavior and the internal sensations that signal the behavior. The second stage is charting it, like in your assignment. So an individual can keep a detailed record of when they engaged in the behavior, the time of day, the events leading up to it, the emotions they experienced at the time, maybe they were stressed or pissed off, the people they were with, anything that may be relevant, right? So the more detailed, the better, to understand the context of the behavior and to get a sense of the conditions that they were most likely to engage in. So for example, with your health behavior thing, if you could, as a unit of measurement for your baseline frequency, you could say I either exercised or I didn't. That's fine. And the more detail, the better. So if you say, on Monday I exercised 20 minutes with a walk, but Tuesday I didn't do anything, but then Wednesday I did an hour-long aerobic workout, then it's like, what was happening on these days that you weren't able to do anything versus you're able to do this big long workout? So the more detail and self-monitoring you have, the more you can learn and the more you have to work with about what reinforces the behavior you want to change and maybe what needs to change to help you change the behavior. So each of these factors that can elicit the behavior are known as the discriminant stimulus. So a discriminant stimulus can elicit the discriminant behavior. Sometimes interventions need to adjust the discriminant stimulus to ensure successful change in the behavior. So for example, if you're trying to quit smoking and a discriminant stimulus is seeing a bunch of, like, going outside and standing with a bunch of people that smoke, you may need to not stand with them because otherwise it might just be too tempting. So a lot of times, just the act of self-monitoring can lead to change because you now know the context of your behavior, and with this knowledge, you can implement change. And now you see it right in front of you, how often it's happening, when it's happening. A lot of times, just writing it down is enough to start a change. Now, to implement further strategies, the discriminant stimuli in the environment that surround the behavior can be modified. So these are known as stimulus control interventions, which involve ridding the environment of discriminant stimuli that evoke the problem behavior and replacing them with new stimuli that reinforce a new response. So if it's hard for you to stick to like a balanced diet when you go to restaurants, maybe changing certain restaurants and replacing them with healthier options, for example. Another example, if an individual is prone to overeating at night, like snacking when they're watching TV, may rid the environment of foods that may trigger overeating. Like, I know I can't stop at just like a bowl of chips. I'll have the whole dang bag. So if I'm trying to avoid that, I just don't have it in my house. And you can replace them with healthier options or put up healthy food guides like Canada's Food Guide or images on portion control. And when we talk about CBT, there's a huge emphasis on the participation of the client in their own behavior change and in their own treatment. So there's a heavy focus on the beliefs people hold about their own health habits, so the C in cognitive behavioral therapy. People often generate internal monologues, which can either interfere or encourage their ability to make a behavior change. And think about you can think about the prefactual thoughts appendice for your journal. Interfering thoughts, like a person saying they can't quit, these can make an individual less likely to change a behavior. So as a result, modifying thoughts are a part of CBT approach. So you got to change the narrative in your head. The belief that people's thoughts impact their behaviors underscores the importance of involving people in the therapeutic process as their own co-therapist. The involvement of a client in their own care emphasizes CBT's reliance on self-control, that the client acts as their own therapist and learns to control both the antecedents and the consequences of the behavior with the guidance of their therapist. So the therapist acts as a guide and kind of just helps point the client in the direction, but the client is doing all the work. Thoughts on the behavior can be modified using cognitive restructuring, which trains people to recognize and modify their internal monologues to promote healthy behavior change. So the idea is that we have all these thoughts during the day. A lot of times they're just automatic. They just pop up on their own. And a lot of times, even though they're just automatic and they just pop up, we give them a lot of power and we have them hold a lot of weight. But thoughts are just thoughts. They may or may not be true. Like, I could have a thought pop up that, I want to win, I am going to win $1 million. Doesn't mean it's actually going to happen. That would be nice, but no. So, for example, if a smoker has a thought that they're weak and they can't resist their cravings, that doesn't mean it's true. And it can really impact your ability to not smoke. So this thought can be modified and replaced with a more helpful thought. Like, this is really hard, this is really difficult, and I can do it. I did it before, I can do it again. So CBT incorporates also self-reinforcement, which is the systematic rewarding to increase or decrease the occurrence of a target behavior. Positive self-reward involves rewarding oneself with something desirable after successful modification. Negative involves removing an aversive factor in the environment. Similar to self-reward, self-punishment can be used to stop a behavior. Positive self-punishment is the implementation of unpleasant stimulus to punish an undesirable behavior. Negative self-punishment is the removal of a positive stimulus to punish an undesirable behavior. Self-reinforcement is usually more effective than self-punishment because self-punishment relies on the individual actually implementing the punishment. And how often do we want to actually punish ourselves and do things that we don't like? However, one form of self-punishment that is effective is contingency contracting, in which an individual forms a contract with another person detailing the rewards and punishments. They might do that with their CBT therapist. CBT is also huge for behavioral assignments, which are home practice activities that support the goals of therapeutic intervention. So this technique increases client involvement because it gives them real-time opportunities to see their success at making behavior change. For example, a client may practice their self-monitoring over the week. So there are a lot of advantages of behavioral assignments. So first, the client is involved in their treatment and is an active participant in their treatment and their improvement. Second, the client produces a useful analysis in planning future interventions. So you can go out, complete your behavior assignment, and then come back to the next session and talk about how it went and use that information to guide future assignments. Did it work? Did it not work? How come? Where do we go from here? Third, clients become committed to the treatment process through a contractual agreement between the client and the clinician. Fourth, responsibility is slowly shifted out of the therapy session and onto the client. So it's no longer just something you do for an hour a week in session. It's really starting to transition it slowly into the real world. And last, as homework assignments increase, so does the client's sense of self-control and self-efficacy. So I've been able to do so much, I'm in control here, I can do more, I can keep doing this. Now, I have a slide on classical and operant conditioning that I have a lot more detail on the slide that I'm going to say here, but just a quick overview because CBT really utilizes conditioning to shape behaviors. And the two main forms of conditioning are classical and operant. So classical conditioning is that pairing of an unconditioned automatic reflex with a conditioned reflex or with a new stimulus to produce the same reflex. So this is the same thing as Pavlov's dog, where he realized his dog would salivate when it saw its food, and he paired the tone of a bell to that food enough times that eventually when he took the food away, the dog would salivate just from the tone of the bell. The food didn't have to be there anymore. So with classical conditioning, you have your unconditioned stimulus that produces your unconditioned response. So the food always produces salivation. It's just automatic. And you pair that unconditioned stimulus with a conditioned one. And over time, you can take the unconditioned one away, and the conditioned stimulus should produce the same response, which would now be the conditioned response. So over time, the bell produced salivation even without the presence of the food. So a common example is antabuse for people who have alcohol addictions. Antabuse creates nausea, vomiting, gagging when there's alcohol present. It makes you sick when you try to drink. So eventually, with antabuse is the unconditioned stimulus that automatically produces that response of vomiting, gagging, etc. So the idea is that over time, even without antabuse, the thought of drinking or drinking will be the new conditioned stimulus that produces the response of gagging, vomiting, etc. For any of you that have pets that you've tried to train to do anything, you can probably use that as an example when you're training your animal. In comparison, operant conditioning is the idea of pairing a voluntary behavior with consequences. So this is the same thing as the self-punishment and self-reinforcement that we just discussed with CBT. So reinforcement is something to encourage a behavior. Punishment is something to stop a behavior. And both can be either positive or negative. So positive is putting something there, negative is taking something away. So with positive reinforcement, if I'm trying to get up in the morning, like on a regular sleep schedule, I've said before that I have a really bad sleep hygiene. So with positive reinforcement, when I do get up, I have something that I like. I give myself something to encourage the behavior. Maybe I get pancakes. Negative reinforcement, I take away something I don't like to encourage the behavior. Like maybe I don't have to do the dishes, like I can get my partner to do it, something I don't like. Positive punishment is to stop my sleeping in. So positive, I add something I don't like to discourage sleeping in. So maybe I do have to do the dishes, or I have to work later to account for lost time. Negative punishment is taking something I like away. So maybe I don't get to play Pikmin, which is a Nintendo Wii, GameCube, Wii U game. So with operant conditioning, there's a schedule of reinforcement. So when do you reinforce something? You can reinforce continuously, which is every single time. So give the dog the treat every single time they sit. However, this is more vulnerable to extinction because you expect the reinforcement every single time. So it's more noticeable to not get the treat when they've gotten the treat every other dozen times that they've done it. And extinction is when the behavior stops. So a better option is to reinforce on a intermittent basis. So it doesn't happen all the time, but it does happen every once in a while. So the behavior will keep going with the hope that the reinforcement will eventually happen. Another behavioral skill that may be implemented are things like social skills, assertiveness training, and relaxation training. So some poor health habits develop because of anxiety and stress, and these skills can help reduce those things and address those psychological issues that can be resulting in these poor behaviors. Social skills training or assertiveness training involve training the client in methods that help effectively deal with social anxiety, assert boundaries, etc. In comparison, relaxation training involves things like deep breathing and progressive muscle relaxation. So these can be used to combat stressful circumstances that may maintain poor health behaviors. So if people have a cigarette when they're really, really stressed, you can replace that with things like deep breathing and progressive muscle relaxation to reduce the stress and then hopefully have them not turn to smoking. So in deep breathing, it's just as it sounds. You take controlled deep breaths, which reduce heart rate, reduce blood pressure, taking you out of that fight or flight mode and back into that rest and digest mode. In comparison, progressive muscle relaxation involves relaxing each muscle in the body progressively to discharge tension or stress. So, for example, clench your toes really, 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 really tightly and now let them go. And then clench your knees, lock your legs really, really, really tight and let them go. And doing that progressively through your body to release the tension. So, no matter what you do to try and change a behavior, there's a huge issue of relapse. So, when we say relapse, we don't always mean, although it's included, relapse back into addiction, where it's a particular problem, but basically just falling back into any behavior that you've been trying to change. So, what constitutes a relapse may vary, but the issue is that small lapses often lead into a full relapse of the behavior. So one cigarette doesn't mean you have to go back to smoking every day, but often that happens. And this can be attributed to the abstinence violation effect, which is that feeling of a loss of control after violating self-imposed rules. So like, well, crap, I just broke my own rule. Here you go. I fell back into it. I give up. So this is really common with all or nothing rules, like saying I can never drink again, I can't have any ice cream, I have to exercise every day. The more stringent the rule, the more susceptible you are to the abstinence violation effect, because the easier it is to fall off when it's so all or nothing, right? So this can lead into a full relapse because you feel like you've lost your footing and your reserve falters. So when we look into why people relapse, especially when it's something that's really unhealthy for you, why wouldn't you want to stay with the new behavior? There's a lot of reasons, but vigilance and negative affect are common. So over time, vigilance fades, leading to increased likelihood of relapse. So for example, people may find themselves in situations where the temptation is too high. Like if you were trying to not smoke anymore and you avoided parties with lots of smokers, areas that you could smoke, etc., and you find yourself back in those places, your vigilance may falter because you're in such a tempting area. And another common situation is low self-efficacy. So thinking you can't change the behavior. Or this false sense of security, so thinking you've beaten the problem, so giving in would not have significant consequences. Like, I quit, so I can just have one. I'm good. And lastly, a common reason is negative affect. So relapse is more common when people are stressed, anxious, depressed, etc. Because a lot of times, whatever this behavior is, it can be a comfort for those negative feelings too. So because there's a lot of reasons to relapse, prevention should be integrated in the programs from the start. So it's better to plan and assume that it could happen and try and prevent it than to just hope that it doesn't happen. So the good news is that there's a lot of techniques to prevent relapse. So a common one is problem solving in advance. So ask people to identify situations that might lead to a relapse. Think of your situational temptations document appendix for your health journal, where you have to identify times that you might want to engage in the behavior. So this is similar to identifying discriminate stimuli and self-monitoring. Identify the situations that might lead to a relapse. And by doing this, you can develop coping skills to manage these events. So for example, you don't want to lose out on opportunities. Like maybe you like to go out dancing, but you're trying not to drink. You don't want to have to give that up just to avoid drinking. So you can come up with skills to cope so that you can still go out and dance and just say no to a beer at the bar. A second option is by engaging in constructive self-talk to talk themselves through tempting situations. So this aligns with cognitive restructuring and replacing thoughts like, what if I have a drink, with things like, I can do this, I'll just have a water instead. Things like that. A more difficult but very effective solution is cue elimination, which is ridding the environment of cues that can elicit the behavior. So this is effective in controlled situations, and I guess, in a way easier in controlled situations, like at home, like ridding the house of alcohol or ridding the house of a food, like of junk food, but more difficult in uncontrolled situations like restaurants and social gatherings. So it can be very effective because the temptation isn't there, and it can involve a lot more sacrifices and be a lot more complex and less easy to control. But a long-term strategy is lifestyle balancing, which is leading a person to make other health-oriented lifestyle changes. So, like a lot of weight loss commercials like to say, like, it's not a diet, it's a lifestyle. A lot of times those aren't true in those commercials, but the idea has some validity that if you try and make it a lifestyle, it takes a lot less effort because it's just built into the habit of how you live your life. So it's more difficult to maintain a healthy behavior change when you're also engaging in a bunch of poor health behaviors. So by engaging in a variety of health behaviors to promote an overall healthy lifestyle, the chance of relapse can be reduced. So there's a lot of advantages to all these techniques, like these CBT techniques. And a main one is that it can deal with all aspects of the problem. So, for example, self-monitoring can identify the target behavior and stimuli that elicit the behavior. Then stimulus control can help modify the antecedents of the behavior, modify that stimuli that can elicit the behavior. Then self-reinforcement can control the consequences of the behavior. So giving yourself a treat for doing a good job. And then social skills relaxation training can replace maladaptive behaviors with an adaptive one. So there's CBT skills that can hit at every part of things that lead up to a behavior, maintain it, etc. So it can kind of hit at every element. Second, the plan can be tailored to each individual problem. So if you've been listening, I've been using examples like smoking, diet, exercise. These don't work with just one problem. You can use them for a variety of things. So I've used these to help people reduce their pot smoking. And I've also used them to help people, like with my example, get up in the morning, drink less coffee. So they can really be tailored to almost any health problem. And last, these multimodal interventions, using a variety of different things, can help modify several health habits simultaneously, encouraging a healthy lifestyle. So when I've done work to help people reduce their marijuana use, if they've had other things to develop that healthy lifestyle, when we were self-monitoring, we self-monitored all of it. So you can try and adjust multiple things. So the last aspect of chapter 3 is that I'll be touching on is the idea of social engineering and venues to modify behaviors. So social engineering is when the environment is modified in ways that affect people's ability to practice health behavior without the people having to do it themselves. So it kind of takes the option out of your hands, so you can't engage in it. So, for example, these are often socially, legally mandated. So, mandatory vaccinations for students. You no longer have the option to engage in this health behavior, you have to. Or not drinking and driving. Like, it's just not an option anymore. And there's a lot of different venues to modify behaviors. So in the practitioner's office, where a healthcare practitioner can develop an individual plan for you to modify a behavior. Families can undergo change behavior together and model health behaviors for younger individuals, establish a routine. Self-help groups can be really great to have people come together and support each other through behavior change. Schools, behavior change interventions can be part of the curriculum, like say gym class, cooking classes. Workplace interventions, like job site promotion programs to change behavior. I did a placement at an inpatient psychiatric facility, and the team there was doing like an activity challenge to try and use alternate methods to get to work, like not drive, maybe bike or walk. Community-based interventions, like door-to-door programs, if anyone ever did jump rope for heart when they were a kid. These can be really advantageous because they reach more people than interventions in limited areas, and they build on that community social support. Mass media can be useful to reach a lot of people. However, the reach can be wide but shallow. Maybe you just see a commercial or an ad or something. So modest attitude change is common, like, oh, that's a good idea, I should do that. But the amount of actual behavior change is a lot lower. Low-cost interventions can be implemented with landlines and cell phones. So automated phone interventions can prompt people to maintain a health behavior. It also facilitates social connection, like texting your friend, reaching out to people. And then we have the internet, which has a lot of information at a relatively low cost. And there's a lot of online programs out there that offer e-coaching, which can provide people access to healthcare with less access to practitioners to a larger amount of people. Like, for example, we're doing a lot more internet therapy, like telehealth right now, with a lot of offices closed. So that concludes the areas of chapter 3 that I'll talk about. And now we're just going to go over chapter 4. So like I said, we're going to cover exercise, accident prevention, vaccinations and screening, and then sun safety practices. So this chapter 4 is talking about the principles of chapter 3 and how they apply to health promotion behaviors. So each of these is important because they've been related to at least one major cause of illness and death in westernized countries. And the first one to talk about is exercise. And this behavior is imperative for improving and maintaining all aspects of health, especially mental and physical aspects of health. So evidence has shown that the risk of several chronic diseases and early death increases the more you sit around, the more sedentary you are. Unfortunately, there's also a high degree of lack of exercise. So adequate physical fitness is seen among only 42% of adolescents. So we're not moving as much as we should. So moving your body is really important. Historically, health practitioners believe that only aerobic exercise could provide the health benefits that you need, which is, high intensity, long duration, endurance exercise. So things like distance running or biking. But we know now that any kind of exercise is helpful, especially for middle-aged and older adults, regardless of the intensity, particularly if your starting point is very low to begin with. So when I think back to when I first started exercising regularly, I went from 0 to walking my dogs around the block, which is like a 5-minute walk. And then to just doing like at home, your hip hop abs, turbo jam, P90X stuff. And then I went to the gym. But I was seeing a lot of benefits because I was starting so low, and then I would just build up from there. So it doesn't take much, and it all depends where you're starting from. You don't need to go crazy and spend a lot of money. So the fourth slide, including the title slide of the first part of chapter 4, you'll see this massive list of the health benefits of regular exercise. It is long, and this isn't even everything. As you can imagine, these benefits aren't distinct, they're related to each other. So for example, controlling your weight and improving your sleep are both health benefits of exercise. And those two benefits are related to each other. So you need adequate sleep to help maintain a healthy weight. So these benefits can create a chain reaction of good things to improve your health. A person doesn't need to exercise 2 hours a day to find benefits. So 30 minutes a day can reduce the risk of chronic diseases like heart disease, diabetes, and some cancers. However, although a little can go a long way, over 2/3 of adults don't engage in the recommended levels of physical activity. And about two-thirds don't engage in any regular leisurely physical activity, meaning it's not like they actually went and worked out, but leisurely activity like playing with your kids, walking your dog, things like that. There are demographic differences in activity levels on average, with activity levels higher among males than females, among Caucasians than African Americans and Hispanics, among younger adults and older adults, among those with higher socioeconomic status than lower socioeconomic status. These are relationships, so keep in mind that a multitude of factors may come into play. So, for example, low socioeconomic status individuals may not have the means to access exercise equipment or gyms. They may not live in safe areas where they feel comfortable going for a walk outside. But just so you know, there are demographic factors that come into play. So, how much exercise do you need? So, there's no perfect answer. It depends on a lot of different factors, like how intense we're talking about, and your own demographic factors like age and your starting point. But on average, an adult should aim for either 30 minutes or more of moderate intensity activity most days of the week, or 20 minutes a day of high intensity, vigorous aerobic activity 3 days a week. So the more intensity stuff does get more bang for your buck than the lower intensity, but you can get benefits from both. So moderate intensity might look like a brisk walk every day or doing some yoga, whereas aerobic activity might be things like, jump rope, biking, running, etc. So again, this can depend on your starting point. So if you go from a non-existent activity level to a walk, you can see benefits compared to someone who's already moderately active, just adding a walk. So it depends on your starting point too. So the benefits of exercise aren't limited to physical health, but include psychological health. So benefits may stem from the direct effects from exercise and from secondary effects, like increased social activity, spending time outside. Exercise can improve your mood and increase positive affect, get those endorphins going, decreasing anxiety and negative affect. Indeed, exercise is a common form of behavioral activation used in the treatment of depression. You need to get your body moving to help your mind heal. When I'm working with someone who's depressed, I'd say 9.9 times out of 10 in my limited window of experience, I'm only a few years into my training, but almost always my first question is, how much are you moving? Because when you're sad, you don't want to move. You want to stay on the couch. And moving is exactly what you need to do. Further, exercising can give people a sense of autonomy and self-efficacy. So they're capable, which can improve general well-being and extend to distal areas of their life. They feel capable. They feel like they can do things. So this can extend to other areas. Like, I feel like I can do this, which means I can probably do this. Also, there's an economic benefits. So the healthier you are, the more productive you'll be. Employee fitness programs have been related to decreased absenteeism, so less days off, increased job satisfaction, reduced healthcare costs. So there's huge benefits of exercise. And I think this is a huge conversation right now with gyms closed and people stuck at home and really struggling, right? So what makes someone more likely to exercise? When we look at people who exercise and those who don't, or just exercise less, we see a lot of common characteristics. So like we discussed in chapter 3, it's imperative to instill behaviors early on in childhood, so they may become habits and become automatic. However, when we look at our youth, only half of them are getting the recommendations for them, which for young children, it's 60 minutes of daily physical activity a day. Now, much of this activity can be built into the school curriculum, but even this is kind of endangered as there's budget cuts, right? And it doesn't account for weekends and holidays, or right now with schools being closed, it doesn't account for times that you can't rely on the school curriculum. Moreover, without instilling exercise habits at a young age, it becomes increasingly difficult to introduce exercise later in life. Regular exercise declines in adolescence, as do health behaviors overall. And in adulthood, we have decreased time and resources and increased stress, which are all barriers for regular exercise. However, many adults do exercise. So who are these people? So on average, individuals who come from active families, so those habits that were instilled in childhood, who have positive attitudes towards exercise, have a strong sense of self-efficacy to exercise, these people are more likely to be active. Also, energetic, extroverted, sociable people, people who perceive themselves as athletic, have social support in their exercise, like to exercise or like the exercise that they're doing, and have a sense of responsibility, so that internal locus of control that I can help my health. All these factors make people more likely to exercise. So it's not like you have to have all of these, but each of these factors has been related to greater incidence of exercise. So if you think about all the exercise programs out there that try to create something fun, you're more likely to be active if you're doing something that you enjoy. In addition to personal characteristics, obviously external things can impact the likelihood of exercising. So improving accessibility to exercise, making settings convenient and easily accessible will promote fitness. So also safe, less crowded settings will facilitate activity. If you feel like you don't have room to move around or you feel unsafe, you won't be comfortable working out. So, for example, I don't like working out at the gym without a women's only area. I feel really vulnerable and exposed and uncomfortable beside all the boys that are, doing their big thing. I feel really exposed and kind of looked at funny and ugh. So I hide out in the women's section. When I have had to work out in co-ed gyms, it takes a lot more effort. I find I don't work out as hard because I'm already like kind of 1 foot out the door. So you need to feel like you're safe and you have the room to move around and you're in an environment that you feel comfortable in. Further, a lot of exercise options are expensive and inaccessible for people with financial constraints. So improving environmental options can help facilitate exercise, like especially when there's free options like walking paths, recreational facilities, swimming areas, things like that. Social support has a huge impact on the likelihood of exercising. So if any of you guys have had gym buddies or just workout buddies in general, so this helps with this commitment to another person to increase exercise. It'll increase likelihood that'll happen, even if you don't actually go through the exercise with them. So for me, I find a workout buddy is really helpful just to get me there. I just need to get there, and then you're in that mindset that this is where I am, this is what I do. So I just need that buddy to get me there, and then I just want to go off and do my own thing. But you're still making that commitment to the person to get yourself in that situation. However, no matter all these other things, the best predictor of future behavior is past behavior. And this holds true for exercise. So the best predictor of future exercise is developing a regular exercise program. Long-term practice of exercise is heavily reliant on habit. So people usually drop out of exercise programs within the first 3 to 6 months, after which it's more likely to be habitual and sustainable. So if you can get through the 3 to 6 month hump, you're more likely to keep going in the long term. So if you think about those New Year's resolutions, exercise, weight loss, whatever is probably one of the most common ones. And January to March, the gyms are packed with people, especially people who probably got like a few months as a Christmas gift or something. And afterwards, people start to drop off because people will stop their exercise programs, don't make it through that 3 to 6 month hump. And it takes willpower and a belief in your personal responsibility to maintain exercise for the sake of your health, especially when exercise doesn't necessarily come with immediate benefits, right? So if people exercise in a way that they enjoy and that's convenient for them and they're motivated to do so, then they can develop goals around this and they'll be more likely to continue it long term. So when we're trying to get people to exercise and we develop interventions to encourage people to do so, what do those look like? Because we're bombarded every day with countless attempts to encourage exercise. And a lot of them are just from corporations in the weight loss and fitness industries that are just going for a healthy financial gain. So despite this, underneath all the, money makers, there are a legitimate influx of interventions that have shown success at facilitating exercise. So, these successful exercise interventions will incorporate principles of self control, so enhance those beliefs in self efficacy and health as within your control and within your responsibility. Further, successful exercise interventions can increase motivation to change exercise habits and increase your personal activity. So, like phone reminders, like maybe take the stairs or park farther away from the door. And these interventions will promote your personal values. So, remember, if something aligns with your values, you're more likely to do it. So, an intervention can be successful if it promotes a value of health, fitness, activity. Also, interventions may facilitate general lifestyle changes. So, one health behavior change may promote behavior change in another, which can facilitate an overall healthy lifestyle. Some exercise interventions have been developed for families with some success. So, the goal here is to induce all family members to be more active, and this really leans on that social support to facilitate exercise. And these same interventions have been implemented in other group areas like seniors' homes, workplaces, etc. As with any health behavior change, relapse prevention has to be incorporated to increase long-term adherence to exercise programs so you make it past those 3 to 6 months. Relapse prevention in this case can include problem solving for difficult times, such as exercising during the holidays, when you're out of town, when you're out of equipment, like right now when the gyms are closed. It can be so easy to stop exercising without your usual equipment. You have to change a lot. So for individuals that don't have a habit of exercising, lapsing into a sedentary lifestyle is a risk, and problem solving can help prevent relapse. So next up, we have accidents and accident prevention. Accidents are one of the major causes of preventable death worldwide, and this cause of death is increasing. More people are on the road, more people are using mechanics, technology. Of all accidents, home accidents are the most common causes of death and disability for children under the age of 5. So, for example, kids get into everything and they can ingest poisonous substances, fall down the stairs. So, to prevent home place accidents, particularly for children, caregiver courses have been developed to educate caregivers on what home dangers are and to prevent them. So, to help them see the things that could be dangerous for kids that they may not have seen on their own. Specifically, homes can be baby-proofed by installing safety catches and gates in the home, poison stored out of reach. Further, caregivers can teach children safety skills to instill a sense of responsibility for their own health and safety. As with young children, older adults are at a high risk of accidents. So, fall-related accidents are a common cause of death and injury in older adults, and 25% of adults are hospitalized for at least a year due to injuries from a fall. So consequently, a large focus has been placed on developing strategies to reduce fall risk and injury among this population. Much fall prevention programs are delivered to older adults and their caregivers, including healthcare professionals. So first, interventions can be focused on diet and medication to maintain the physical health of the older adult. So like maintaining bone density and muscle mass to lessen the risk of fracture and lessen the risk of fall. Secondly, you can recall that exercise is particularly helpful among older adults. So this population may require altered forms of exercise to suit their needs, but still regular physical activity training can maintain and improve balance, mobility, gait, flexibility, and reduce the risk of falls and injury from falls. And lastly, the environment of an older adult can be adjusted to remove fall risks and put additional safety measures in place, like grab bars, better lighting, handrails, non-slip flooring. Another common accident site is on the road. So motorcycle and automobile accidents are the greatest cause of accidental death. Accidents on the road can be attributed to a bunch of different things, like how people drive, how fast they drive, distractions when driving, like cell phones, food, etc. So some preventative measures to reduce road accidents are socially engineered, like speed limits, seatbelt laws. In the past few years, a lot of laws have come into place to prevent driving under the influence of alcohol and drugs, especially with the legalization of marijuana in Canada, and especially for distracted driving, because this has become a huge area of focus with the rise in cell phones, and large fines now exist for people caught on the phone when driving, and they seem to be increasing these fines all the time. In addition to these socially engineered solutions, psychological interventions can include presentations to young adults, so getting back to those teachable moments on the dangers of drunk driving, and community-wide health education programs aimed at including and increasing seatbelt usage. However, in this case, it seems as though socially engineering solutions may be more effective. So, for example, areas with mandated seatbelt laws have much higher usage of seatbelts. And our second to last topic for this part of chapter 4 is vaccinations and screening to prevent illness. So these are two ways to either avoid or early detect some chronic illnesses. However, many people don't use either of these resources, making it an important area of intervention for health psychologists to increase these behaviors. So vaccinations can be socially engineered health behaviors, like required vaccinations for children or for healthcare practitioners. However, many caregivers choose not to vaccinate their children and rely instead on the immunity of the majority of children to protect theirs. Like if every child around mine has been immunized, mine should be fine. This decision has been a pretty big topic of controversy, especially lately with the rise of the anti-vaxxer conversation. And this is because a lot of this decision to not vaccinate and concerns around vaccinating your children comes from misinformation that vaccines can cause the disease that they're vaccinating, or they can cause disabilities or other diseases like autism spectrum disorder, which I could go on all day about this, but spoiler alert, vaccines don't cause autism. So, to try and increase vaccination rates, interventions are often designed to try and correct these incorrect beliefs undermining vaccination, like trying to correct the beliefs that vaccines cause autism spectrum disorder. However, that fear of hurting your child by giving them a vaccination, like hurting them trying to protect them, is very strong, and there could be a lot of guilt associated with possibly hurting my child. So other methods to improve vaccination rates can include stressing the social benefits of vaccination. So if your child can't get an illness, they can't spread it to others. So it's not just you, it's the child, it's the children around you, it's the people around you. Some children can't get vaccinated because of other conditions like autoimmune disorders. So they legitimately need to rely on herd immunity of the children around them. And lastly, messages may be aimed at families and adolescents, encouraging them to advocate for their own health and hold these discussions with their family. So, vaccines are used to prevent illness. Screenings are used to detect illnesses early, which can increase the survival rate. Screenings are common to detect cancers like breast cancer and prostate cancer, which are the most common cancers in America. And although routine screenings were once frontline against cancers, like happened all the time, concerns regarding false positives have resulted in a more as-needed approach, because some false positives have led people to unnecessary treatments, even surgeries. So specifically, people who are at risk or already symptomatic for either cancers are encouraged to get regular screenings. For breast cancer, mammograms are used to detect tumors. And mammograms are recommended yearly for women between 45 and 55, and every other year for women 55 to 74. Mammograms are important for older and high or at-risk people because the populations have a higher prevalence of breast cancer, and chances of survival improve dramatically when detected early. Further, mammograms are relatively cost-effective, far less invasive, and less expensive than the treatment that may be necessary for breast cancer once it's developed. However, despite the benefits, as people get older, the use of mammogram declines, and there's a lot of different reasons, like the fear of radiation, embarrassment over the procedure, anticipated pain, anxiety, or discomfort, fear of a cancer diagnosis, like they just rather not know, especially when they're older, concern over costs, a lack of awareness, time, or resources. So, to promote screening, interventions may be directed at changing the attitudes towards mammograms, creating like a positive attitude towards the procedure to facilitate engagement, and interventions aimed at improving social support can improve the rates of screening. So, everyone getting mammograms around you, you're more likely to get one yourself. On a related note, colorectal cancer is the second highest cause of cancerous deaths. And as with breast cancer, older adults are at an increased risk of colorectal cancer and are encouraged to be screened routinely. So, factors that predict screening are alike those previously discussed in Chapter 3 that predict health behaviors overall. So, self-efficacy, perceived benefits of the procedure, physician's recommendation to get the procedure, social norms, like is it socially supported to get screened, a lack of barriers and access to the screening. These can all predict individuals getting their routine screening for colorectal cancer. So interventions to promote screening can be directed at increasing these predictive factors. Community-based education and mass media programs may help improve social norms in support of screening, which can facilitate social support among people. Interventions have been launched through social media to stress the benefits of screening and emphasize self-efficacy so that people have the power to protect their health by getting screened for cancer. Recommendations from healthcare providers are common, but reminder notices can be helpful also. Be sent from a physician's office or even via text to remind an individual that they're due for their screening. And lastly, we have sun safety practices. So, skin cancer in America has increased nearly fourfold in the past 3 decades. And although some skin cancers are rarely fatal, there's malignant melanoma, which is incredibly deadly and kills over 9,000 people every year. So, although skin cancer is incredibly dangerous, it's one of the most preventable forms of cancer. So if it's so preventable, why is it on the rise? And especially when we know that the main risk factor is excessive exposure to UV rays. So too much time in the sun, spending time on a tanning bed. So we know it's a pretty easy shot that if we protect ourselves from the sun, protect ourselves from these UV rays, we're lessening our risk of skin cancer. It's a pretty big no-brainer. However, it's difficult, especially when tans are seen as very attractive. So in a lot of areas, people don't adequately protect themselves from UV rays because they want to get a tan, or just misunderstandings, like you may not wear enough sunscreen, you may not apply it regularly enough, it doesn't last all day, you have to apply it again. You may not have enough of a sun protection factor, SPF. Some people might have skin issues, so they don't want to apply sunscreen. So interventions to increase sun safety practices can focus on educating the public about effective sunscreen usage and the damage of UV exposure. So really going after that, the benefits versus the cost. Like, yeah, tans are great, but do you want skin cancer, or what it actually does to your skin to be tanning all the time? So for example, there was a really clever study that showed beachgoers a photoaging intervention, which showed premature aging that was already happening on their skin without their knowledge. because especially these interventions are especially targeted at adolescents and young adults, because with this population, there's a huge concern for immediate benefits and less worry about distant consequences. So tan now, wrinkles later kind of thing. So in this study, the people that were shown this premature aging were more likely to engage in UV protection than those that didn't. So the take-home message is use adequate SPF, wear sunscreen, reapply regularly, skip the tanning beds. There's a lot of alternatives like spray tans, tanning creams, etc. that exist to give yourself a bronze without the risk. So that concludes everything for this episode. Next week, I will finish up Chapter 4 and go on to Chapter 5, which is health compromising behaviors. Take care.